afternoon. Yes, so speaking about lateralization from the glenoid, the BioRSA, again, thank you very much, manos a manos. I have no conflicts of interest to disclose. So basically what we're going to talk about is what exactly is the BioRSA. We'll begin with the origin and rationale for the BioRSA. I'll briefly explain the technique, and then we'll go through some of the recent results published on it. So the BioRSA stands for bony increased offset reverse shoulder arthroplasty, originally described by Pascal Boileau, and is the use of the humeral head cancellous autograft harvested at the time of RSA. The idea being that you can create a bony lateralization of the glenoid component, which may result in a decrease in mechanical impingement, potentially a decrease in scapular notching, again, potentially an improvement in range of motion, improvement in stability, and improvement in cosmesis. So the traditional Grammont reverse shoulder arthroplasty, the biomechanics are such that there's a medialization of the glenohumeral center of rotation as well as a lowering of the humerus. This serves to reduce torque on the glenoid component, and it increases the deltoid lever arm in order to compensate for the absent or deficient rotator cuff. However, there can be some issues in that there can be some anterior scapular impingement, which may restrict internal rotation, posterior impingement, which may restrict external rotation, and then there also may be limited post-op shoulder rotation due to either excursion of the humeral component around the medialized glenosphere or potentially due to impingement of the tuberosities, such as the coracoid process, the tuberosities on the coracoid process in internal rotation, the scapular spine in external rotation, or the tuberosities on the acromion in terms of abduction and forward elevation. There also may be prosthetic instability if you have, in particular, poor soft tissue tension or glenohumeral impingement. And again, I alluded to earlier, there may be some cosmetic concerns, as Dr. Warner has showed as well, due to loss of normal shoulder contour. So options in terms of increasing offset from the glenoid side include, and I won't go through this in detail because our next speakers will talk about it in more detail, but they include autografts such as iliac crest bone graft, allograft, metal augmentation, patient-specific glenoid components, and then finally BioRSA. And of these options, some of the biggest rationales for BioRSA include its high versatility, no donor site morbidity, low cost, low risk, and such. So these are three diagrams depicting on the left the traditional Grammont medialized arrangement, in the middle a metallic lateralization off of the glenoid, and then on the right bony lateralization using the BioRSA. So this is briefly the technique. So first, a small wafer of the humeral head is excised using the oscillating saw. You see on the left the guide, which we use to put the guide pin in the center of the humeral head. Next, in the middle, we see the reamer, which allows us to produce a cylindrical ream of the humeral head. And then what you have left with is on the right-hand side. So you have the central pin as well as the cylindrical cut. We then use a guide, which you see on the left-hand side, which allows the oscillating saw to cut at a depth. You can then remove the cylindrical portion of bone. And on the right-hand side, you see the cylindrical portion of bone loaded onto the central post of the glenoid component. Now, in this case, you can see that it is tapered, so there is an angulation to it, which can also provide you with an ability to tilt inferiorly the glenoid component, and you can also correct for any posterior wear of the glenoid as well. Drill holes are drilled in the upper portion of the glenoid, you can see the smiley face arc on the inferior portion of the glenoid. That's to promote bony healing of the graft to the glenoid. And you can see the final construct on the right-hand side with the BioRSA glenoid component, but prior to insertion of screws and prior to the glenosphere being placed. So what are the results? Well, we don't have a huge amount of data. This is actually the first published result in 2011 by Dr. Boileau, 42 patients, mean 28-month follow-up. There was 98% complete graft healing and no significant resorption or lysis, no component loosening on the glenoid side, and there was a good improvement in the constant Murley score from 31 to 67. There was, in fact, a pretty significant amount of inferior scapular notching, 19%. And pretty good internal rotation. 86% of patients were able to internally rotate past the sacrum at least. They noted that there was improved range of motion when they compared their range of motion findings to prior published data on the Grammont reverse. Their follow-up study in 2020 looked at 5 to 10 year follow-up data, 143 shoulders at mean 6 years, 72 a month or 72-year-old. The cohort was 72 years old. The mean follow-up was 75 months, just over 6-year follow-up, but minimum of 5-year follow-up. There was a 96% survivorship, no dislocation or humeral component loosening. Again, improvement in the constant score, improvement in subjective shoulder value from 31% to 77%, and very high complete graft incorporation, overall 18% severe inferior scapular notching. On the top right, you can see that their technique changed somewhat. Prior to 2011, they did a standard offset, but beginning in 2011, they started to tilt the glenoid component inferiorly by placing an asymmetrical graft. This is work from Philippe Collin. He published a retrospective cohort study, single surgeon study, looking at 61 BioRSAs compared to 69 reverse shoulder arthroplasties at 2-year follow-up. They noted that the BioRSA improved anterior forward flexion slightly for 145 degrees compared to 138 degrees. Interestingly, they found no difference in external rotation or internal rotation compared to the standard BioRSA. They did find a slightly higher constant score for BioRSA of 69 versus 61 in the traditional shoulder arthroplasty. No radiographic differences, including no differences in scapular notching between the two cohorts. They hypothesized that the lack of difference in the external rotation, internal rotation may be due to their description of the deltoid recruitment, in that with the BioRSA, due to the bony lateralization of the rotation, this decreases the ability for the deltoid to be recruited for rotation, whereas in the Grammont shoulder arthroplasty, due to the medialization of the center of rotation, this would increase the deltoid recruitment. This was their hypothesis as far as the lack of difference in external rotation or internal rotation. This is Dr. Walsh's study, 79 BioRSAs just published this year in 2022, minimum 2-year follow-up. You can see significant improvement in the constant score. Final range of motion was 133 degrees of anterior elevation, 32 degrees of external rotation, and L1 for internal rotation. The notching rate was very low, 3%, no cases of severe notching. There were some radiolucent lines, 11% around the peg and 13% around the screws. And in terms of complications, there was a 3.8% dislocation rate and 5% glenoid loosening rate. There is one meta-analysis of studies thus far. It included 8 studies published last year in shoulder and elbow. Of these 8 studies, there are 235 BioRSAs compared to 150 standard Grammont-style shoulder arthroplasties. There is in fact only one randomized controlled trial, not unexpectedly. At 20 to 36 month follow-up, average patient age of 74 years old, they saw improvement in the constant Murray constant Murray and subjective shoulder values, showing benefit of BioRSA, although these were pretty small differences. It favored BioRSA, the constant score of 4 and subjective shoulder value of 6.8%. So these were not minimally clinically important differences. There was no range of motion difference in any direction comparing BioRSA to the Grammont style, and notching was less likely with BioRSA. The odds ratio was 0.19. 92% of BioRSA grafts fully healed, incorporated, and the loosening rate was only 2.4%. So, in conclusion, BioRSA is a viable surgical option which provides bony lateralization of the glenoid component. It can be used to correct glenoid deformity and improve positioning of the glenoid component. It may decrease mechanical impingement and scapular notching. It may improve range of motion stability and cosmesis. However, the jury is still out on this. And further investigation is certainly warranted, looking at mid and long-term outcomes as well as comparative studies of higher quality evidence. Thank you.